So what I really hope to do today is to tell a story, to kind of tell how cytoreductive nephrectomy came about, what were some of the landmark trials that brought it to popularity, and then how did the introduction of these targeted agents in advanced kidney cancer change that landscape. And then how did that impact cytoreductive nephrectomy over time, leading up to very recent clinical trial data, and how will that affect our practice and recommendations. Also, I want to touch very briefly on partial nephrectomy for cytoreduction, and then just end with some practical guidelines that you might take back to your clinics. So I don't need to tell this group some demographics about kidney cancer, common cancer. I think what's most relevant to this talk is that still in this day and age of lots of imaging, a quarter of patients will show up with metastatic disease. And a third of patients who you do nephrectomies on will end up with metastatic disease at some point in time. Now, that's not going to be probably your 2-centimeter localized tumor. It's probably going to be like my patient here, this extensive T3, 15-centimeter sarcomatoid tumor that we did laparoscopically. So these are the patients that are going to show up with metastatic disease. And when they do, the distant disease 5-year survival is really quite dismal at about 12% versus the localized disease. So in a historical context, I think we all know by now that renal cell carcinoma does not respond to traditional chemotherapy agents. And in the early 90s and 90s, what we had was systemic therapy in the form of interferon and interleukin with very poor response rates, especially with the tumor in situ, very poor response rates in the primary tumor. And so cytoreductive nephrectomy sort of grew out of this idea, and also some animal observations that in animal models, when you did cytoreduction before doing therapy, you could get regression of distant disease. But in practical terms, we didn't really see that too much. I mean, you didn't really see that in the human model, so to speak. And actually, in the mid-90s, only about a quarter of patients were ever making it to systemic therapy after having their cytoreductive nephrectomies. And this is a series out of Albert Einstein in kind of the mid-90s, and you could see the perioperative mortality 17%. I mean, patients were staying months in the hospital. So this was quite a morbid operation. So this is all leading up to 2 landmark trials that both were in 2001, one in the Lancet, one in the New England Journal of Medicine. The top one was a SWOG study. The bottom one was an EORTC study. They were both identical protocols on purpose, and it was the first time we had level 1 evidence in this space, and it was looking at cytoreductive nephrectomy plus interferon versus interferon alone, and who did better. You had to have biopsy-proven metastatic renal cell, and they did randomize patients at this point to performance status, extent of disease. The Mozart criteria, although published at this point, wasn't utilized as an entrance criteria or a stratification criteria. So the SWOG study enrolled more patients than the EORTC, and these were all open surgeries. So lots of Kaplan-Meier curves as a typical oncology talk, but if you're like me and this is sort of maybe not your cup of tea, the curve that's on top is generally the group of patients that's doing better in any particular time point, and you could see separation in these curves. Cytoreductive nephrectomy plus interferon doing better than interferon alone. In the SWOG study, this was a 3-month advantage from 8 months to 11 months, but it was statistically significant. And in the EORTC group, 7 months to 17 months, so much more significant but smaller group. And this held true across risk, across stratification for performance status and the other strata. I keep doing that. So a couple years later, they combined these analyses, which is why they were identical protocol on purpose. And the median overall survival was about 8 months for interferon alone and 13 months and change for cytoreductive nephrectomy plus interferon. So clear survival benefit. It was across all strata. So only in this study, only 5% of patients did not make it to get their systemic therapy. So this clearly cemented cytoreductive nephrectomy in its place for advanced kidney cancer. What about the idea of the morbidity of these surgeries from the 90s? Well, in this group, it looked much more approachable. There were 22% complication rates, only 1 death in the SWOG group. So why might this work? There are lots of theories. I think it's difficult to prove this, but we know that renal cell carcinoma is an immune-mediated cancer, and perhaps the primary tumor is acting as some kind of immunologic sink or inhibition to the immune response to distant disease. We know that there are proangiogenic growth factors from the primary tumor that are probably playing a role. And certainly you could have people who you ultimately give systemic therapy to who may have problems if you leave the primary tumor in. So removing that primary tumor removes that problem. So here we are. We got it. Cytoreductive nephrectomy, that's the way to go. It works for everybody. Sounds good. So not exactly. All along this time frame, there was a separate storyline going on at the NIH, and this was with Dr. Lineham's group figuring out sort of the genetics, the molecular basis of kidney cancer. And I'm not going to go through the mechanism of action. I'm already long on time. But there are lots of targets that arose from this work over a decade's worth of work. And over that, from 2005 to April of 2018, when imolubimab got approved in combination with nivolumab, there have been 11 agents that have been approved by the FDA for advanced kidney cancer, starting with sorafenib and sunitinib within a month or so of each other in 2005 to early 2006. So really an explosion in this space. And these agents were working well. I mean, a lot of the sunitinib studies, randomized controlled trials, I mean, these patients were living 21 months, 26 months. Remember, it was 8 months, without this. So this is a really notable change. And also, you were seeing responses in the primary tumor to the point that some of these tumors that were unresectable were becoming resectable. So I think that kind of changed the conversation a little bit. The agents were more tolerable. But in the same time, all of these patients enrolling in these clinical trials, 90% of them had nephrectomy at some point. And if cytoreductive nephrectomy worked for this crappy systemic therapy in the 90s, of course it's going to work for this great systemic therapy in the 2000s. So I think cytoreductive nephrectomy persisted until people kind of started asking these questions. Well, wait a second. I mean, these therapies are different. I mean, maybe these patients are doing well. What's the timing of them? What's the need for cytoreductive nephrectomy? Some oncologists would propose that if you gave upfront therapy, maybe you could downsize the primary tumor. Maybe you could make it more easily resectable or convert it from unresectable to resectable. Also, maybe you could test the patient out. How do they tolerate the targeted therapy? Are they made of the right stuff, to get to cytoreductive nephrectomy? And if not, if they were going to get cytoreductive nephrectomy and the morbidity was not going to allow them to get the therapy, maybe they could get some therapy up front and get some benefit from that. So again, a lot of retrospective data until I get to the current trial, but there were data that were arising showing benefit, retrospective, but out of large cancer databases, SEER databases, national cancer databases. What you see here to walk you through this, this group of patients had cytoreduction, this group of patients didn't. Red were patients that were treated in the targeted therapy era, and blue were the patients treated previously. So you see a survival benefit in both patients for targeted therapy, but you see this additional benefit for cytoreduction in retrospective data. But in the exact same paper, there was a trend towards decreased utilization since the introduction of the targeted therapy in 2005. You saw this huge uptake, of course, with all the steamrolling evidence leading up to it. But after the introduction of these agents, clearly there was some pullback from the concerns aforementioned. And this was also true in Mayo's database. They saw a 50% reduction in cytoreductive nephrectomy in a 5-year time span. I mean, that's really impressive as the targeted therapy had increased substantially. So what was going on here is who's right for this procedure? And this was the energized interest in risk stratification and the Mozart criteria and the modified Mozart criteria. This is on the right is the IMDC criteria, people adding different prognostic factors, trying to see if you had one or more of these factors, what group would you fall in? And these models were performing very well. You could see separation between good risk patients to intermediate risk patients and poor risk patients. So these were being heavily utilized during this time period, and some patients were not getting to cytoreduction. This is a retrospective series from MD Anderson, and they did something interesting. They looked for 7 independent predictors in their database, and then they kind of layered them in. If you had 1 factor, 2 factors, 3 factors, how were you against the patients who had cytoreduction versus didn't? And you can see that once you get down to like 4 factors or so, these patients were not really doing much better than the patients who weren't getting cytoreduction at all. So this is the idea that if you have a poor risk patient, maybe they're not going to benefit from this procedure. But I caution everybody because this is retrospective data. Here's a patient of mine, lung metastases, and clearly she has T3 disease, she has lymphadenopathy, she had a low albumin, she had a high LDH. It's 4 factors, and according to MD Anderson, this patient's not going to benefit from cytoreduction, but she's 52 years old, she works, she's got great performance status, only lung mets. So, of course, I did a robotic cytoreduction on her, and she's doing great. She is stable to improve lung disease. So I think these risk models are important, but you have to apply it to your individual patient. So in the end, what we had was a massive retrospective data, and rather than going through all those trials ad nausea, I'll just point you to the idea that on this side of the chart, this favors cytoreductive nephrectomy in the targeted era. These are all studies that were done in the targeted therapy era, and there are literally none in this meta-analysis that favored the other way. So clearly, this was enough to power guideline statements to say cytoreductive nephrectomy should be done if feasible. It should be done, of course, in good risk patients. That's the NCCN guidelines. The EAU guidelines from Axel Bex, who I'll get back to in a second, was maybe slightly more pragmatic, mentioning things like if you have a patient with high volume mets, if you have a patient with sarcomatoid variants, you ought to get pause on that, but it's still, the benefit seems clear. Both of these guidelines referenced ongoing randomized controlled trials that weren't to fruition yet until now. So this is Carmina, if you've seen this. This was published last month. It was e-published in June, and it may be very practice changing. And I just want to go through this trial. This is a French trial mostly, but a couple other centers participated in Europe. And thanks to Seth and Axel Bex, who provided some of these slides from GU ASCO, and I appreciate that. This is the schema. You had to have metastatic renal cell carcinoma, biopsy proven, intermediate or poor risk patients only. There were no good risk patients in this study, and they were randomized based on their Mozart criteria. It's important to know that you could have even had brain mets as long as you didn't have them visible for 3 weeks. So these were pretty high-risk patients in this study. But they were randomized to either receiving cytoreductive nephrectomy plus sunitinib versus sunitinib only, with looking at overall survival, and was powered as a non-inferiority trial with 2-year follow-up. Wrong way again. So these are the Kaplan-Meier curves. There's very little separation to none in between these two, but if anything, the curve that's on top is actually for the first time sunitinib alone and not cytoreduction. And you see the median overall survival for cytoreductive nephrectomy is 14 months versus 18 months without cytoreductive nephrectomy with sunitinib. You see the same holds true for progression-free survival. So obviously, this is very interesting for level 1 data. What about contamination in these groups? This is the idea that maybe you were assigned to cytoreductive nephrectomy and sunitinib, but it just didn't work out. You didn't make it to get your sunitinib, you didn't make it to surgery. Or what about the patients who went on sunitinib arm, but then ended up getting cytoreduction? And you see there are 17% of patients in that arm who actually did end up getting cytoreduction. So there was some substantial contamination between the 2 arms. And busy slide, don't worry, we're gonna trim that down. This is the numbers we already spoke about. The point I want to make here is that was on an intention to treat analysis. That means that no matter what arm you were put in, no matter what happened to you, you were analyzed according to that arm. But if you analyze the patients as terms of what they actually had done, if they had cytoreduction or not, if they got their sunitinib or not, then this survival spread that seemed to favor sunitinib was maybe a little less, and you see that at this point the hazard ratio is approaching 1. Safe procedure, 16% complication rate for major complication rates here. So remember, it was 22% in 2001. It was very, very high in the 90s. So clearly we're getting better at this surgery. So this was a statement made at GU ASCO. Cytoreductive nephrectomy should no longer be considered the standard of care in metastatic kidney cancer. And I think that's a pretty powerful statement. Dr. Russo and Dr. Motzer wrote an editorial on the same issue of the New England Journal, and I think it's a really good editorial, and it points out some of the important, shortcomings of the study and maybe potential of the study. So if you average out the patients, there were 80 centers that participated in this trial. If you average them out, that's less than 1 patient per center per year. And there are data that show that the higher volume at a higher center improves overall survival. So that's interesting. Memorial had 24 patients per year eligible for this trial for the same study period, just to give you an idea of volume. The cytoreductive nephrectomy group had a higher percentage of T3 and T4 patients, but by a good measure. And so without having data like renal vein involvement, lymphadenopathy listed in the trial, we know that those patients have more of that, but there's not that information in the trial. And also, as I mentioned, sunitinib has had really great overall survival benefits in randomized trials, much higher than what was reported in this trial. And so it leads to the question, well, are these high-risk patients? I mean, maybe these weren't the right patients to get cytoreduction anyway. So I think I'll summarize this for time. Basically, don't give up on cytoreductive nephrectomy. Think about your patients and who might be good risk and who might be poor risk. One last quick trial. This is from Axel Beck's, a really interesting trial, randomized, prospective, multi-center trial, this one out of the Netherlands, where he looked at the timing of cytoreduction in relationship to sunitinib. In other words, this idea of upfront therapy. Does it matter in terms of patient outcomes? And I think an important point of this study was, unfortunately, they really missed the mark for accrual. They needed 450 patients. They were thinking 3 years. In that same time period, they accrued 60 and change. And after going a full 7 years, they accrued 99 patients. So ultimately, their endpoint was changed to be progression-free rate at 28 weeks. Not sure how much that we can glean from that. But there are some important things to the study, which is why I bring it up. These were better risk patients, by the way, no more than 3 negative prognostic factors. I just want to make these few points. The idea is, boy, if I start my patient off sunitinib, am I ever going to get them to surgery? Or is there going to be some problem that happens when I give them this therapy? This trial would say no. Of the 48 patients who underwent cytoreduction, only 2 of them had delayed a surgery more than 2 weeks that were sunitinib related. So most of them were other things that we all see, logistical issues or comorbidities. And then, boy, if I give them this targeted agent, I mean, aren't they going to heal worse? Aren't they going to have worse complications? Actually, not really. And if anything, there seemed to be a benefit towards delayed nephrectomy with giving sunitinib up front in terms of less adverse outcomes, maybe downsizing the tumor, maybe making the procedure a little bit easier. No real difference in the Kaplan-Meier curves. And the overall survival analysis, which clearly this was not powered to look at, there was a trend towards delayed nephrectomy. So I think all we can glean from this really is the idea that it would be safe to do this and give your patient cytoreduction afterwards, and it's a reasonable strategy in patients who might not be able to get there. So I'm clearly out of time. I'm just going to touch really briefly and say cytoreductive partial nephrectomy, you can do it. There's, again, only retrospective data on this, and the numbers are small. If you look at a SEER database that has 2,000 patients for cytoreduction, they had 46 patients who had cytoreductive partial nephrectomy. So clearly some challenges to analyzing this data. But in multiple series at UCLA and Roswell Park, these are the overall survival and cancer-specific survival is similar to cytoreduction. Probably some other factors going on there, clearly smaller tumors. This is a patient that I did that on, small segmental vein thrombus, but objective indications for cytoreduction, and so we identified that thrombus robotically and pulled that thing out of there, and this patient did very well. So in conclusion, I'm over on my time, but I just want to say that metastatic renal cell carcinoma needs interdisciplinary conversations and tumor boards, and you need to talk to your oncologist. You need to assign them to a prognostic risk group and see, are they going to benefit from cytoreduction or not? And I would leave you with this proposal, that if you have a patient that has relatively low metastatic volume and good performance status, I think that's the right patient for cytoreduction. That might even be the right patient to start doing metastatic metastastectomy on, which I don't have the time to touch on that today. Happy to answer questions, before giving the systemic therapy. If you have a patient that's maybe poor risk, poor performance status, then maybe you want to think about giving targeted therapy up front. How do they handle it? Maybe it's going to make things better, and maybe do a delayed cytoreductive nephrectomy. But if you have a patient with high volume Mets and their poor performance status, this would be a patient that probably should go to targeted therapy, and you can decide whether or not they ever make it to a palliative procedure. And they should be offered clinical trials. So thank you.